next speaker, I'm going to ask um, Charles to introduce Dr. Thwaites.
Okay, so our first speaker today is Dr. Dwayne Thwaites, and he will address back to basic, understanding prostate cancer and the various symptoms and impact. Dr. Thwaites, a diplomat of the board of the American Board of Urology, was born in Antigua and Barbuda in the Caribbean and did his medical training at the University of Miami School of Medicine and then at Downstate University in Brooklyn, New York. He did his residency in the Department of Urology at Emory University School of Medicine. He has conducted important research and published many articles and wrote two chapters related to the field of urology, including a chapter on transurethral resection of the prostate. In November 2019, Dr. Thwaites was awarded the Most Illustrious Order of Merit for distinguished contribution in the field of medicine and community services by the government of Antigua and Barbuda, where he currently resides and practices. And as a fellow Kittian, I want to commend Dr. Thwaites for the work that he's doing in the Federation. Dr. Thwaites?
Hello.
Go ahead.
Good morning. I was going to say, well, I can't even say good morning because we're so international. I got to say good day. And I did enjoy that little talk from our comedian. I must say that I'm proud to be a part of this this conference. And one of the things I must say is that the Walnut Foundation with Dr. Isaac has been with me for a good period of time now, doing most of my work in the Caribbean, specifically in St. Kitts. And we know with prostate cancer and it being so prevalent in the Caribbean itself, that the support group is a necessary entity to help people recover from prostate cancer. We're going to talk a little bit about prostate cancer, back to basics, and the way how it's presenting, and where I'm doing most of my work in the Eastern Caribbean. We've been doing prostate screening in the Eastern Caribbean between Antigua and Nevis for 13 years. And we have also done about 5 to 6 years in St. Kitts and Nevis. We'll get to see the difference between the screening process in the different islands and look at the data for a little bit. But for most of us, prostate cancer, we see a change in world in making the diagnosis for prostate cancer. And as the Consumer Guide report would say to you, some of the 3 cancer tests that you need and 8 that you don't. And one of them that they had presented back in about 2011 was that PSA doesn't really save lives. And you don't really need it. But it's not everything that you see and hear you should really believe. We were told back by the United States task force that we do more harm from PSA screening because we overdiagnosed and making people sick in pursuit of health. PSA screening for prostate cancer really does set off a cascade of events. But with good, proper screening, we can prevent some of these events from occurring, and we can do a lot of good treating people for prostate cancer. We had great expectations from PSAs and digital rectal examinations back in when it first came out. And we did see a rise in prostate cancer then, and we also saw a rise in the recovery and treatment of prostate cancer back in the 90s. We screen for prostate cancer because detection and treatment of disease condition, abnormality, stunted development at a stage which no symptoms have yet appeared. As we all know, and most of the people who have had prostate cancer, the presentation is basically no symptoms. You don't really know you have prostate cancer until it's very late stage. And so we know that with screening for prostate cancer, there is an effective treatment. And there is no point for early detection if no effective treatment. In other words, when we do screen, if we pick up the disease early, we can treat it, and the cure rate is about 95% for the early stage prostate cancer. I tell my patient, just to be on the safe side with them, this is almost like common cold. You come in, we pick up the disease, we can treat you, we can cure you of the disease if we pick it up early. We do have some side effects from the treatment options, but those we can assist you with as you get out there with time. But we can cure you of the disease. Most people really don't know what your physician goes through when he makes the diagnosis of prostate cancer, or even during the screening process. I got a call yesterday from one of my patient's husband. He's 50 years old and he died from prostate cancer. And one of the reasons this occurred is because he never came in for screening. We've been screening in Antigua for 13 years. We do it on a Saturday. It's completely free, but most people don't have the time to come in and screen for prostate cancer. And so what they do, they come in at late stage. We know that prostate cancer is very prevalent in the Caribbean. It's because one of the things is that we have a high risk population for prostate cancer. Worldwide, a man is diagnosed with prostate cancer every 3 minutes. And a man dies of prostate cancer every 18 minutes. Our worst nightmare with prostate cancer, if we don't pick it up early by screening, is that we get non-metastatic hormonal resistant prostate cancer, or even the metastatic hormonal resistant prostate cancer, because our treatment armamentarium is very poor. We can't do anything for that. So therefore, early screening for prostate cancer is an imperative. It's imperative that we do so. These are some of the famous people that you know around who have had prostate cancer, who have been treated for prostate cancer, and who have survived. Picking up the disease at an early stage, really help us with the treatment options, and men get to live a longer life. Again, the side effects, little incontinence, and some erectile dysfunction are things that we can handle and we can treat. These are some of the guys from Antigua who have had prostate cancer. And most people will know Dr. Ramsey, who has passed away, and our fearless leader, Lester Bird. The mortality rate and the incidence for prostate cancer is very high. The death rate for prostate cancer seconds only the lung and bronchus. And if you notice, the time frame when we see the peak in prostate cancer is around 1993, 94. And that's about when we started to look at the development for screening for prostate cancer, when PSA was approved by the FDA, and when we started to do digital rectal examination. Catalona had invented the idea of doing both the digital rectal examination and the screening. Again, prostate cancer leads in incidence. It's second in mortality to lungs and bronchus. This is my most famous slide. I like this slide very much because it shows you a time frame when PSA was discovered, when we started to use it, and when the United States Task Force in 2011 came up with the idea that this PSA screening was not a necessity. But when we start to look at most of the data and everything, and when 2011 started out and they said that it was not necessary, when we start to look at prostate cancer now, in 2020, we're noticing now more and more a rise in late stage prostate cancer, people coming in and dying more from prostate cancer than before 2011 because they're not being screened appropriately. And so therefore they're now coming back, which is what we were seeing back before 1973, people coming in with late stage prostate cancer. So we know effectively that prostate cancer screening does its job. and we pick it up early and we can cure people of prostate cancer. Again, this is one of our great inventions, the steel pan from the Caribbean, just like PSA and digital rectal exam has come about and has helped us to determine early stage prostate cancer and treat people effectively. We look at the data comparison to male and female. Again, prostate cancer, if you notice the rise and the peak, it's around 1993, 94. That's when we started to use digital rectal examinations and PSA to pick up prostate cancer early, started treating it, and then it started to drop off because we were doing the right and correct thing. It's starting to speak again because of the United States Task Force coming out and saying that screening is a class C. We look at the world map again, the Baltic states, epidemiologically, we see a lot of prostate cancer in the Baltic states, the colder parts of the region, and again, the US. And if you notice the Caribbean, we've had a very high prevalence of prostate cancer. The World Health Organization has deemed it an epidemic proportion in the Caribbean itself. So we look at risk factors. Prostate cancer, most common type of cancer found in men. It's second only to lung cancer as the most common cause of cancer death, which we show again. Black men in particularly has the highest rates of prostate cancer, and it's higher than most of the Caucasian population. Again, one of our other risk factors besides being Black is your age. We notice the most incidence of prostate cancer at the age of about 65. 25% of all cases are diagnosed under the age of 65. So therefore, early screening is imperative. It's important. People need to go out and get screened. And of course, one of our biggest contributor for risk factor is family history. I talk to the families all the time. In my database in Antigua and the Eastern Caribbean, I know a sector of the population whose family have high risk for prostate cancer. And so therefore, those people have to come in, and I try to screen them at an early age. The younger ones come in at age 35. And so we start screening these people early just because of their last name, because it's such rampant in their family. Again, genetics is very important. You never know who is carrying this gene for prostate cancer. And diet is a big thing. This is back in the day in Antigua, someone turned in what we call some fungi, or turned cornmeal, as they say in Jamaica. And we know that fatty foods will increase your risk for prostate cancer. There've always been some studies coming out from out of Canada, the Canadian Urological Association, showing that the amount of ejaculations per month also decreases your risk for prostate cancer. So these are some of the things. We know that fresh fruits, vegetables decreases. There was some study coming out of the American Urological Association, which is showing that red meat might increase your risk for prostate cancer. So there are some things that are out there that is that. This is a study which was done from a group from Pittsburgh who went down to Trinidad and Tobago and noticed that the population was of West African ancestry. The descendant was from West Africa. And what they found was that there was a germline on the chromosome 8q24, which predisposes these West African descendants to prostate cancer. And so we notice the Caribbean is a mixture of people. I remember when I was training at University of Miami, a Jamaican, a white Jamaican came in, and he put on his history and physical for his race, he put other. So my professor called me in and he said, why did this guy put other on there? I said, the Caribbean people are a mixture of people. He can't really tell you what he is, but he is really an other. But we must bear in mind, we are still a high risk population for prostate cancer. Again, we look at the death rates, it's higher in the Black population. And we could see the trending downwards as we go along to 2014. Again, the Asian population, the Hispanic population, they're all lower than the Black population. Again, higher incidence and death rates among the Black population. So that puts us in a high risk population. Hence, we need to screen. We need to screen at the age of 40. If you do have a family history, you probably should come in at an early age. No matter how you look at it, even in your imagination, it is bigger in Black people. It's definitely bigger in Black people. We look at age and race. Again, we lead when you're between the ages greater than 65, you have a higher increased chance of developing prostate cancer. That's one of your risk factor. Age, race, being Black, you have an increased risk for prostate cancer. Family history, again and again, those are the basic baseline. And then we look at PSAs. The higher the PSA, the more likely that you will have prostate cancer. Again, screening has led to a shift towards identification of early stage disease, and we can treat these people and they can recover. Again, 95%, 5 years going out. If we pick it up early, we can do any of the treatment options, being it watchful waiting or active surveillance, radiation or surgery. Again, there is definitely an absence of randomized trial documented the detection of aggressive treatment can reduce mortality. There was one study that came out of Europe, the European randomized prostate cancer screening study by, I think it was Schroeder, which showed some example of improvement with that. But we haven't really had many more randomized controlled studies. The pendulum swings both ways. You come in, if you get it early, we pick it up early, we can cure you. If you decide that screening is not important, then you will more than likely come in with late stage prostate cancer. We need to get a medium in between. I think that what we need to do is smart screening. Your urologist will tell you what we need to look for, what we need to do in order to screen, and who needs to be screened. There is no need to rush to make the diagnosis. We just need to take our time and systematically decide how to screen these people and who we're going to go ahead and treat. PSAs, for most of the primary care physicians, we need to understand that there are other things that can cause the rise of PSAs. So when the patient comes in and says to you, look, my PSA is elevated, you need to calm them down and tell them there are other things that can cause the PSA to go up. BPH, benign prostatic hyperplasia, retention of urine, prostatitis, even if we get a transient rise after ejaculation. What we need to do is look at the PSAs and try to figure out if this is an important rise in the PSA. There are some things that are out there that helps us improving the performance of PSAs. I know, again, as I showed you with the initial size, there was this criticism of the PSA. We could look at PSA density, age-specific PSA, PSA velocity, free PSAs. They have their downsides, but your urologist, with an understanding of all of these factors, can smartly determine whether or not it's important for him to go ahead and proceed with the biopsy. Again, the goals that we need to reach after we have decided and make a decision that you have prostate cancer is to reduce the mortality, to reduce the morbidity, reduce the development of painful metastases. When people are dying from prostate cancer, it is very painful. Again, we know this because we see people are coming in now again with the late stage disease because we are not doing the appropriate screening protocols because the United States Task Force has said screening is not important. Again, our limitations, as I've said before, false negative results. The patients get very anxious about doing their PSA, the PSA examinations, and waiting for their result. Again, if we pick it up early, we can treat. If the disease is small, it's not growing fast, we don't have to aggressively treat these people. We can do active surveillance, and so we can reduce the side effects of aggressive treatment. The anxiety, just to tell someone to bend over to do the prostate examination is very, very unreal. Most people don't like it, it's not. And Again, the AUA best practice guidelines determines what we need to do. Basic principles of screening. You have to do both the PSA and DRE. I know for a fact that there are people out there with low PSAs who have abnormal digital rectal examination. One year we did the screening and we screened over 1,000 men, and most of the patients who we picked up with prostate cancer had a low PSA but an abnormal digital rectal examination. There are protocols that we need to go through, understanding that your PSA can be elevated for other reasons. We need to be sure when we are going towards the biopsy, because there is a cascade of side effects that can occur when you do a biopsy. Infections, people get hospitalized. So you have to be absolutely sure as a urologist that this person really needs a biopsy. Attitude is everything. Perfection is the enemy of good. We just need to be sure before. We don't need to be perfect. We just have to work with what we have and make a concrete decision that these persons need a biopsy. Smart treatment and screening for prostate cancer is what we need to do. Advantages of detection with PSA screening: early diagnosis when we can cure you. Again, 95% 5 years for T1C disease, early stage disease. Reduced risk of medicine and morbidity. It really does. Early screening can prevent that. There are a couple of studies out there that shows that. Reduce risk for death from prostate cancer and improve overall survival. These people do very well. We can cure the disease if we pick it up early and do the appropriate treatment. The disadvantage, again, the anxiety that we go. They claim we're over treatment of some tumors, but the data out there are saying that is not true. And again, increased costs for screening complication. When we don't screen, the advantages is a reduction in the lifestyle. The person goes on living until the disease gets to them. And this is where the disadvantage comes in. We do pick up late stage disease because you don't screen. Again, you end up spending a lot more money trying to treat the disease and trying to survive when we don't really have a good armamentarium to treat the disease. If prostate cancer is found at an early stage, we can treat and teach. This is just a slide showing you the bright lights of St. John's, Antigua. Harms and benefits: prostate cancer reduction, life years, again, reduction in advanced disease. Can't keep telling you that this is important. This is basic principles for screening. If we pick up, we can treat, and you're doing. Again, they claim overdiagnosis, overtreatment, and late time in years. This we can handle if we do it appropriately, if we do smart screening. Again, life is sweet. It's sweet like a Julie mango. We need to protect it. We need to do what's right. When we looked at the data between Antigua over the last 13 years that we've been collecting all this data, again, with screening, we see a decrease in late-stage disease. People are not coming in with late-stage disease that we cannot treat, that we cannot handle. In St. Kitts and Nevis, what we noticed was the difference between the water between the two countries. The Nevis people were screening. The St. Kitts people were not screening. We did 13 years of screening in Nevis. We did 5 to 6 years of screening in St. Kitts. And what, again, we found was that the late stage disease were the ones we were picking up in St. Kitts and Nevis because the people were not screened. Just a little difference in water, a little difference in mentality have proven to us that screening is important. There was a study out of Austria which showed the same thing. There was a study up in the Nordic states with Denmark and the other countries, the Baltic states, where they were doing the screening. The Danes weren't doing the screening, and they found more people were dying from prostate cancer in the Dane study, and most people come in with late stage prostate cancer. Again, there is a difference between screened and non-screened, and you need to go out and screen. Intelligent screening does save lives. We know that for a fact. We should encourage screenings, especially in a predominantly high-risk population. If you have high risk, which is the Black population, which is the Caribbean population, we need to do prostate screening. It gives men more time with their families to listen to the music, sail their boats, and smell the roses. It's a beautiful sunset. This is what we live for, so we can see the beauties of life. It's only when mosquito lands on your testicles that you realize there's always a way to solve problems without using violence. And my favorite side, life is like a penis, simple, soft, and straight, and hanging freely. It's women who make it hard. Thank you very much. And thanks for having me, guys.
So, Dr. Thwaites, there are a number of questions that have been presented. So I'm going to ask the guys to read out the questions and you can address them. Anthony?
So, Doctor, okay, Anthony, you can go ahead.
Go ahead. No, go ahead, Andrew.
First question presented was, does Dr. Thwaites offer active surveillance to low-risk patients? And what percentage of patients are on active surveillance? Is active surveillance an acceptable strategy for Black men?
Absolutely correct. I do offer active surveillance after a long discussion with the patient. Majority of the Caribbean men will come in and want to go for active surveillance. One of the things that I do explain to them when they tell me they want to active, are you sure and comfortable that you can live with the fact that you know you have a disease that is curable and you want to watch it? Our biggest problem, again, for the machismo men in the Caribbean is that erectile dysfunction is about 40 to 50% with any of the other treatment options, be it radiation or surgery. And so for most men don't like that. And again, the second thing is the incontinence, wetting yourself at about 3 to 5%. They don't like that. And so most men will go for the active surveillance, especially the younger men. The problem is that what I'm seeing more and more is that as we start to watch and watch, then the PSA changes, then they get a little bit nervous and then they start to worry. And they worry a lot. They come in all the time. They don't wait for the proper time for follow-up and they get worried. And so they end up from active surveillance into surgery. It's important to understand that there is an entity of prostate cancer that is very slow growing indolent. If you have the ability to sit and watch it, then I usually recommend the active surveillance for most men. But again, we see it changes. About 25% of my patients go on active surveillance. 75% do. And I must say, majority of the people who go on active surveillance end up changing and coming back and want to have a procedure done. It's difficult to live with the fact that you know you have prostate cancer. And so most of them change their minds after a year or two and they come in. Bear in mind that most of the studies out there are showing us that it doesn't make a difference if you get treated now or treated later. But I must say, majority start off, but then they change their mind along the way.
There is one more question, and it says, how important are genetics genetics testing in the West Indies versus the United States and Canada?
Well, we don't do a lot of genetic testing in the Caribbean. We just don't have the ability to do so. What I do is evaluate the family, talk to them, and do a family history when you come in. A very most important part of an evaluation for someone who comes in for PSA screening is his family history. And if your family history demonstrates that you have a high risk for prostate cancer, that your uncle, your brother, and everybody, most people in your family have prostate cancer, I then suggest that you move forward, you get a full prostate screening on a yearly basis. I also suggest to the family that the younger men, 35, can come in and get screened. I had a classmate of mine whose PSA was about 3.4 at the age of 35. And the primary care physician kept on just watching him. when he came to see me, I said, but I asked him a question about his family history. He said, yeah, my uncles, my father, all of them had prostate cancer. So a 35-year-old guy with a PSA of 3.4 is definitely an elevated PSA. He has a strong family history. That guy needs to be biopsied. And lo and behold, we biopsied him. He had prostate cancer. I've treated him, and he's doing very well right now. Again, the major concern for most people is the side effect, erectile dysfunction. Again, we have medication which can help you. We have different tools that can help you if you can afford to get these medications. It goes a long way. But we do not have the ability or the capability of doing the germline testing. But what we do is look at your family history.
Okay. The next question is there a possibility that your team can assist Grenadian men with screening, given the prevalence of that disease?
Absolutely. And you know what's funny is that working in Antigua, you have a wide cross section of the islands who live in Antigua, who come up from the different islands. And one of the things that I've noticed, especially in the French islands between Guadeloupe, Dominica, St. Vincent, and St. Lucia, we see a lot of prostate cancer. Again, there was something on the internet about the chemicals during the sugar plantation in these islands, which have caused an increased rise in cancer, per se in Guadeloupe and Martinique. Again, Grenada, I see a lot of Grenadians come in with prostate cancer. Yes, we can do something to help you. We have been trying to branch out to the different islands. Again, it's difficult. It's hard work. And it's sometimes difficult to get professionals. Again, some people like to tell me walk with the general practitioner. And there's some good general practitioner who could do a good exam and do everything. But I like to get with me the urologist, because I know we have to do, which is what I've been pushing, smart screening for prostate cancer. We have to be smart about doing it because of the fact that they're saying we overdiagnose and we overtreat. We need to make sure specifically that what we do is the correct maneuver to help these people. But yes, we can set it up. Again, we look a lot of sponsorship. Again, the Walnut Foundation has been with me in St. Kitts, and I really appreciate them. They do bring out the men because they go about in the community. Dr. Isaac, we're going in the community, talking to the men, telling them about prostate cancer, getting them aware. Awareness of prostate cancer is so important. The news media, the web binders that we do, everything that we do out there help us get this. The disease is very prevalent. Remember, before we finish talking today, we will have at least 5 to 6 men who would die from prostate cancer. Every 18 minutes, somebody dies. So awareness, we can do more screening. No bother with the people who are saying that screening is not important. There are multitudes of data out there have shown that screening decreases the risk for prostate cancer. It decreases the late stage, and it prevents you from getting horrible disease entity, which we cannot treat. It is important to understand that smart screening is important. People who do random and just do all kind of different things make it worse for the people who can do the screening. The urologist should, at the end of the day, make the decision of where to go forward with the prostate cancer and how to treat.
Next question.
What was the reason why the FDA reduced the need for PSA? Was racism behind this decision making?
I don't know. This is one I understand. And there was a study, the American study, the PLECO study, which only studied the prostate cancer and screening for about 6 years. And in their group, they had a lot of older people, unhealthy people, and they looked and they said the need for treatment was about 1 in 48 or 1 in 50, whereas for breast cancer, the need for treatment was 1 in 12. But in that, the United States Task Force group, there were no oncologists and there were no urologists in the group to determine whether or not this was so. And we, the urologists and the American urologists waited because now we're seeing the difference. We noticed the difference back in 1973, 74, 93, 94. We noticed when PSA was first developed, we noticed people were dying from prostate cancer. It started to drift down. And then now Since 2011, it started to climb back up, late stage disease. Important to understand that that study from the PLECO, which the United States Task Force used, their patient population was just totally not right. When the European Schroeder and the European guys looked at their study, the number needed to treat was 1 in 12, 1 in 14, which is just consistent with breast cancer. But there was no turning back with the United States Task Force. Lots of the primary cares joined with them and saying, yeah, this is not, men are having problems. Men having impotency because of the treatment. People are getting infected because of the biopsy. These things, as they're a small amount in the population. It has nothing to do with racism. It's just one of the studies that they looked at and they determined that this was not so. But we are proving that it's not so. Most urologists and doctors have proven screening is very important, especially in a high-risk population.
Next question is, how many Caribbean countries do you work with, and how often should one get tested?
I screen again for a Black population or a high-risk population. Let me not just clarify it as Black. A high-risk population, people with family history, we screen once a year. I work in 3 islands. I work in Antigua, St. Kitts Nevis, and Tortola. Tortola has a good program for screening with the Red Cross, which they've been doing for many, many years. They haven't been using their data, but I see there is good correlation between prostate cancer, late stage disease with their data, which they haven't been using. But we have been looking at the data between those islands. Again, I see patients between Anguilla and Dominica who comes up for evaluation and for treatment. So those are the islands I do most of my work in.
So there's a question in the mail that came in through email, and it says, is TURP a one-time procedure, or can it be repeated when needed? And does TURP procedure have an effect on erections?
Okay, now what we do know is that no, TURP, the prostate does regrow, it does, and it can reoccur. The longevity for the gold standard, which is the regular TURP, is about 10 to 12 years. That's what the longevity is. So your prostate can regrow. The understanding is that when you do a TURP, you don't completely remove the prostate, you remove the inside of the prostate, and so it gives the tissue potential to regenerate and it can come back. So at around 10 to 12 years out, we do see the regret. There was some data out there saying that you might get erectile dysfunction, and they think that is so from doing the TURP, because if you TURP it close to the capsule, understanding that the nerve runs on the outside of the capsule. So when you're doing the electrocautery and shaving the prostate down, there is about a 2 millimeter gap where they think that the electric cautery, the current can go through and damage the nerve, and which will cause erectile dysfunction. There's not been anything demonstrating that happens. One of the other studies has shown that in about 30% of the men where you do a TURP, that their erectile function comes back. So it's a controversial issue. We don't see much of it causing erectile dysfunction. Again, if you go close to the capsule, you can get a transference of the electrical current over. Nowadays, people are doing different things for BPH. You could do the Urolift, you could do the thermal energy, and the laser TURPs are very good. The depth of penetration for the laser is very less than the electrocautery, so we don't see that many, if any, no erectile dysfunction doing the TURP.
Okay, we have one more question because we're sort of running out of time. So this next question is, I have had an increase in PSA reading the last 2 years. I had a biopsy which was negative. I did another PSA a few weeks ago, and the reading went down from 8 to 6.6. Is this a good thing, or just the way the readings can fluctuate?
It's usually the way how the readings can fluctuate. Consistency and keeping follow-up is important. What I usually do is look at a standard figure for, let's suppose someone comes in and it's 8 and I do a biopsy. I watch that person, and if it doesn't go above 8, if it goes above 8 and it continues to rise, yes, I will definitely for sure do a repeat biopsy in quick succession. If it goes down, I will continue to watch. The standard of care is really that if you have a negative biopsy and the PSA still remains elevated, that you should really go back and repeat the biopsy 2 years later.
So Dr. Thwaites, are you going to stick around to the end?
I'm going to try my best.
There are a number of other questions that are coming in, but we've got to move on. And so at the end, we're going to try and address all those questions that weren't addressed. And I'm really encouraged at the number of questions that have been coming in.
Okay, I'll stick around and try and answer as many questions as I can.
That'd be great. So thank you very, very much. Really appreciate this.